This is geared more towards coaches. It looks like most of my audience here will know most of what I'm talking about, but I'm going to go into some detail with it, kind of thinking about this in terms of for coaches and things like that. So maybe they'll have a better understanding about what it is that the athletic trainers are doing. And additionally, if they view this, and there isn't an athletic trainer for some reason at their specific site, if they're away or what have you, they'll kind of have a better understanding about what to look for, etc. Okay? So concussion. This is an update that I've done. This is based upon the Berlin consensus statement for management of concussion in sports. This is updated. I update this every few years, whenever they do come out with a new concussion guideline. And so this is based upon the most recent consensus statement. So what exactly is concussion? Most of what we see about, we term concussion comes, and what we know of from the literature comes from military. So the term concussion was initially used in the military to describe concussion blasts or for bombs. So if you see these, like these pictures from like Vietnam with these big aerial bombardments, and you see the bomb go off and then the trees sway back and forth, well, that's transmitted energy through the air from the initial concussion blast and then a secondary force being propelled outward from there. So you've got your blast and then an energy pushing somebody back if they were standing here. You can think about that in terms of if I've got an acceleration and deceleration impact, then and an injury, you've got a brain that's stationary here. By inertia, it stays put, it's sitting in fluid. If you've got a concussion blast, it's going to go forward, and then when you stop your momentum, it'll come back and like hit the back of the skull the other direction. So that's concussion. It's a force that's acted upon the brain. So we'd use the term for military. So go into more definitions. What exactly is a concussion? SRC, you'll see it in the literature, it's termed sports-related concussion. This is to actually delineate it from non-sports related, because typically, if you think about it in terms of litigation, motor vehicle accidents, you'll find that most people in sports are actually wanting to get back, whereas there's potential for work loss and other things. So they you'll see in the medical literature, they're differentiating the sports-related concussion from the management of just regular concussion and how you deal with it and such. So sports-related concussion, it's caused by either a direct blow to the head, face, neck, or elsewhere on the body with an impulsive force transmitted to the head. So technically, if you get hit on the finger and that force is transmitted to your brain, you can technically have a concussion. Typically results in a rapid onset, short-lived impairment of neurologic function, and it resolves spontaneously. There's nothing that we can do to make it go away faster. It's going to go away on its own. Some signs and symptoms evolve over a number of minutes to hours. Can result in pathologic changes in the brain. Acute clinical signs and symptoms largely reflect a functional disturbance rather than a structural injury, and that means that 95 to 99% of these will have no abnormalities on neuroimaging. It's a functional issue. And it's a range of clinical signs and symptoms, may or may not involve loss of consciousness, and the resolution of these signs and symptoms typically follow a very sequential course. You've done this long enough, you can see somebody. If you are a practitioner in sports medicine, then you're going to be able to say, by such and such a time, you're probably going to be okay. But you have to follow them clinically, because it typically follows this like sequential events, and it doesn't always. Okay? And you've got to essentially rule out any other cause. So if all other causes are not there and it meets all of this, you have a concussion. Okay? You'll see in the medical literature mild traumatic brain injury as a synonym. This is to differentiate it from traumatic brain injury, which has much more, it's not definitively defined in the medical literature, but typically with traumatic brain injury versus mild traumatic brain injury ends up with significant sequelae that is long-term and long-lasting. Okay? But there's a little bit of overlap between MTBI and TBI. For the most part, we don't deal with traumatic brain injury. That's in the military literature, motor vehicle accidents, and things like that. So what is our goal as clinicians, as the people on the sidelines? So we need to identify immediate neurologic emergencies, okay? Because most of these are not neurologic emergencies. So we're looking for the ones that are bad. And then recognition of the concussion. Okay, we need to recognize that this is a concussion, and then management of that concussion to try and prevent any type of problem later on. And then the prevention of cumulative and chronic brain injury. Okay? That's our goals. That's really what it boils down to. That's what we're trying to do here to safeguard these kids. We'll kind of go through this pretty quickly. There's about 1.74 million traumatic brain injuries in the U.S. Most of these are mild traumatic brain injuries. Motor vehicle accidents account for most of them. Falls, next, occupational accidents, recreational accidents, and assaults. But again, this is not just including our specific demographic, okay? Now, if you look at mild traumatic brain injury causes, American football is the #1 cause, okay? And if you look at this, the incidence is about 20% in a season. So if you get 5 guys in front of you that are playing football, one of them is going to have had at least 1 concussion by the end of that season. Pretty high. So from an athletic training perspective or a coach's perspective, am I actually recognizing that many during the season? Do I have that many kids out? Probably not. So we miss a lot of these. So American football, 10% of players in a college per season. There's debate as to why that actually exists. It's lower than high school per season. It could be the difference between the malleability of the brain. As you age, is it not as easy to get a concussion? Is it due to neck strength? All these things, the bottom line is we don't know. Okay? We don't know why that is, but you tend to be more prone to them the younger you are. Males greater than females, about 3 to 1. And about half of the patients with mild traumatic brain injuries are between the ages of 15 to 34. So this is during the very active phases of your life, whenever you're participating in these types of events. Okay, we are going to, I say you have this, we're not going to go through the pathophysiology. It's a lot of science, but the best way I can describe it is this. This is your neuron, okay, this is the basic neuron. There's a lot of things that happen, lots of shifts with electrolytes, et cetera. But globally, in rat models, you can't biopsy somebody that has a mild traumatic brain injury that's a human. So most of this, you give rats these mild traumatic brain injuries, you biopsy their brain, you see what happens. And if you look at all of the neurons, what you get is axonal shearing. You get kind of like rips and tears and stretches within these axons, just kind of globally. Okay? So all of this, to show you a picture, that's pretty much what we can, okay? And it doesn't show up on neuroimaging. Unless there's some that we're trying to map these pathways now that I'm curious to see as the technology advances as to whether or not you can diagnose this with neuroimaging at very special centers. But that's probably another 5 to 10 years down the road. So what do we typically see in concussions? This is typical early clinical findings, but it's not absolute, meaning you may have all of them, you may have none of them. It's very, very wishy-washy. Confusion, amnesia, retrograde, which means events prior to, anterograde, events following. We, in the past, debated, okay, which one's worse? Is there any difference in which one is worse? And really, no, there's no correlation. But you can see amnesia. Loss of consciousness always freaks people out, but it can happen. Headache, dizziness, vertigo, imbalance, lack of awareness, nausea, vomiting. Yes, hypersexuality, alterations in the mood. Pretty much anything that affects your cognitive function can occur with a concussion. It is a global phenomenon. What about late onset clinical features? So, you've sent them home, they come back and see you on Monday. They can still have mood disturbances, sleep disturbances, sensitivity to light, sensitivity to noise, concentration difficulties, headache, et cetera, et cetera, et cetera. It's just more of the same. They just tend to linger on, okay? What about seizures? People always freak out about seizures. Well, definition of early post-traumatic seizures occur within 1 week after a concussion. So that's still considered early, even if they start having seizures 1 week after, okay? Within 1 week after. Most of them occur immediately following. If you're going to have a seizure, it's immediately following. These are actually considered acute symptomatic events of just a concussion, okay? Not viewed as epilepsy. They occur pretty rarely, in less than 5%, mild traumatic brain injury. Over half occur within the first 24 hours. I'd say the majority of these occur immediately. And over a quarter occur in first hour. Let's see. The earlier the seizure, the more likely it is to be generalized. And from a clinician standpoint, you may get asked this by a parent, anti-seizure meds may help control the seizures, but it's actually, they don't decrease the risk of MTBI epilepsy. So these people do not end up on long-term anti-seizure medications, okay? Do y'all remember a pretty high-profile player in the college level that had a pretty good seizure following a concussion several years ago?
That happened in Maryland?
Yeah, but I remember Tim Tebow. I remember he had one. He actually had that nice fencer's pose, I can recall.
It's interesting you said that. One of my good friends is a football coach, and his daughter 2 days ago fell at basketball practice, got hit, and she had a seizure.
Yep.
She has a concussion, and he called me on the way to the hospital, was really worried because she seized, you know.
Yep.
You know, I told him, I said, that may be effective for having a concussion.
Yes.
It was. You know?
I'll guarantee you, because of it, if I'm on the sidelines, I'm going to send that person to get a CT because of the rarity of it. But you can at least say, yes, we're going to do this to make sure there's nothing going on, but you can also assure the parents that most likely it's still going to be just a concussion, okay? But yeah, I would personally recommend anecdotally to send them because it does freak you out.
They did a CT on her.
Yeah. Okay. So what are some complications long term? This is what we're trying to prevent, okay? Remember, you don't have findings on standard imaging. You can have brain contusions, localized ischemia, edema, mass effect. You can, and really, what are you looking for? And this is kind of, how do you discern whether or not, and we'll go into more detail with this, who gets sent to the ER and not? Neurologic deterioration. So you go and you assess them. You say they have a concussion. Don't just leave it at that. Go back, do serial neurologic examinations on these kids. They should remain stable or improve. If they're going down, they've got new findings, send them. It's not worth the risk. Send them to get a CT of the head. Because you need to be thinking about, well, do they have an evolving intracranial hematoma? You know, that's intracerebral, subdural, or epidural. And they look like this. Okay, that's what you don't want to miss. So signs of a worsening intracranial hemorrhage, worsening headache, any focal neurologic signs. If you'll notice what we kind of saw with the concussions previously, it's more of a global phenomenon. They have changes in their mood. They have changes in their sleep. They have they become hypersexual. They don't recall things. There's a cognitive issue. If you have a focal neurologic sign, so for instance, hey, they have a concussion, now they can't feel their hands. Or they have an absent deep tendon reflex in the left patella versus they've got a perfectly normal one on the right. Or now they've got a blown pupil, like one's blown, the other one's fine and reactive. Send them, okay? If they've got a focal neurologic sign, I would recommend sending them. Confusion is plus or minus, okay? Because how many of these people, this is just based upon the data, how many of these people have confusion? Almost 100% of them, okay? I think this is lawyers just covering their rear ends, okay? Lethargy falls, I think, probably underneath this confusion aspect, because lethargy is when, hey, I'm talking to you now, even though I'm confused, but now I'm just kind of like, send them, okay? Progression to loss of consciousness. So, if they had a concussion, you know, they're having a seizure, of course you're probably going to send them anyway. But if they're down and they have a loss of consciousness and then they wake up, well, you can probably watch them. But if they go back to a loss of consciousness, or if they didn't have a loss of consciousness initially and now they're having a loss of consciousness, send them immediately, okay? Again, all of this kind of underlines repeated neurologic examinations in the acute setting. Okay, reminder, and this is definitely for y'all as well as the coaches, MTBI is associated with other injuries to the head and neck. I should probably change this to sport-related concussion now. Skull fractures, this is the battle sign, so you're going to be looking for a hematoma in the posterior auricular area. Any neck fractures, remember that if they're unconscious or they're significantly confused, they technically can't clear their C-spine. So if you suspect a C-spine injury, put them in a collar, get them over there, okay? Now, if they're somewhat confused, but they can answer your questions, yeah, I don't hurt here at all. No, you're fine, you're fine. You can probably clear them. But if they're just kind of like really out of it, you can't clear their C-spine. Spinal cord injuries, eye injuries. Oop, I just kind of said that. Okay. I don't think we can get on YouTube here, so. What I saw here, this was a video of a soccer player. Two soccer players go up to head the ball. One of them drills the other one. He jumps like tremendously high in the head. He comes down and he's unconscious. The player is so freaked out about it, he's like apologizing. He goes up and lifts the guy up and like starts shaking his head. Hey, wake up, wake up. Like, you just hit this guy in the head. He came down, he's unconscious, and you just may have like just pithed him essentially. So don't do that. I have seen that on the football field too. Oh, yeah. I'm not going to name any names, but I've been on the sidelines and going, what are you doing? So be proactive to your kids. Don't let them do that. Okay, acute evaluation and management must be performed by a licensed trained medical professional. In the medical legal world, this includes physicians on the sidelines, this includes athletic trainers, and if there is no athletic trainer, it means the coaches. They are in that chain of command, and this is why they need to have these in-services, because there may not be anybody else that can do it. And so you're performing a neurologic assessment and a mental status and cognitive assessment. Most of the time, this is more for my residents, but before we continue, you recognize that the Glasgow Coma Scale does come into play, but pretty much if you've got some significant neurologic compromise, you don't have to go through all of this. Pretty much if they have a GCS of 13 or less, you're going to be sending them to the ER anyway because it's significant neurologic decline and you're not going to want to watch them, okay? But there are standard examinations out there. There's the SAC, or the Standardized Assessment of Concussion, the Westmead Post-Traumatic Amnesia Scale, Post-Concussion Symptom Scale and Graded Symptom Checklist, and then the SCAT, which is now in the 5th iteration of it. Most of these are pretty long and are used in the clinic setting or the emergency room setting, but Jamie actually sent me, was it yesterday or the day before, our protocol, which I think is fantastic, and he also sent, they have pocket versions of this, which are more like what you can use on the sidelines, and it's actually down and dirty, what I'm going to use in the heat of the moment, and that's really what you need to use. So the SAC was one of the first ones used, standardized tool for sideline evaluation, measures orientation, immediate memory, concentration, delayed recall, neuroscreening, and exertional maneuvers as well. And you have a graded symptom checklist, which is a bit long, but it is pretty sensitive and specific for concussion. Let's see. So this is just another one. I'm not going to go into detail because it really doesn't help you with the sideline management of concussion. In my opinion, it's too long. SCAT 5, again, is too long. It was first endorsed by the Consensus Statement on Concussion 2008. It's a review of subjective symptoms. It goes to the GCS, the Maddocks questions, which are the questions which I'll go into in here in a second, which are useful. It also includes the SAC cognitive assessment and eval of balance and coordination, and it's a point scale of 0 to 100. Interestingly enough, there's no standardization that says it's graded on a 0 to 100. It's way too long to use on the sidelines, the whole thing, because it combines a whole bunch of different things. I use it more in the clinic setting to kind of like pool a whole bunch of data and decide whether or not this person has a concussion. But it's graded on 0 to 100, but there's no cutoff to tell you whether or not you have a concussion. It's really just gestalt. Like, I've seen a concussion long enough, I've seen many of them, you've got a concussion. So it still boils down to that clinical judgment. And so that's where y'all come in. You make that clinical judgment. Do you have that concussion? So this is just the symptom that the scale that the patients will look at, and they'll grade the severity of their concussion symptoms. And interestingly enough, you can use this to try and get a sense for who's going to progress more rapidly in their recovery. Those that have fewer symptoms and not as severe symptoms will probably recover much quicker than those that have multiple symptoms and are rating them as moderate to severe. So the Maddocks questions, these have been studied and proven to be pretty darn sensitive and specific for concussions. And they're very specific, so if you delineate them from these, then it actually kind of, it's not tested, it's just not scientifically proven. What venue are we at today? Which half is it now? Who scored last in this match? What team did you play last week or the game? Did your team win the last game? Okay? I'll tell you also that people will, it's amazing. Concussions are interesting things because if you suspect it, my recommendation is still to hold them out for a series. because there's sometimes later findings with the concussion. And so some people, especially the really, really intelligent ones, they can tell you this stuff even though they're out of it. And so if you suspect it, say, okay, I'm just going to hold you out for a little bit, and then they may come up to you and say, hey, why am I on the sidelines? You know, it's just, the brain is a very phenomenal thing these guys will fool you. So if you suspect, if you have a high index of suspicion, hold them out for a series. Sometimes they'll show you that they have a concussion, and go back and retest them. Additionally, you need to get everybody else away. The kids absolutely love making fun of these kids that have this concussion. Just get them out. Get them out of the way. All right, what about neurocognitive testing? Things like impact, Galveston orientation and amnesia test. There's a bunch of different ones. They're actually not well validated. They're getting better. I use them as adjunctive testing, but not a diagnosis. They're better if you have a baseline. And a lot of times what I'll use these is as a tool to prove to either coaches or families that they're not ready, okay? Or to discern whether or not there's something else going on. Like if they just blow, let's assume that they just have a headache still. And so they've got a baseline impact test. I'm going to retest them because this is the only symptom that they still have. And if they blow it out of the water, I'm thinking, well, do you have a sinusitis? You know, even though I'm not finding any signs or symptoms of it, I'm looking for other reasons for you to still have this, okay? So there is a tool, it's a tool that you can use, but they're getting better with trying to figure out who can like sandbag the test and whether or not these can be learned. Let's see. And then the question of can you bomb the test at baseline, a lot of these are now being able to tell whether or not you are actively trying to bomb the test so that whenever you do have a concussion, you can beat the test, okay? So they're doing a better job of actually recognizing this and kind of putting things in place where you don't have to, you can't do that type of stuff. What about imaging? Most studies done are in the ER setting, not sideline. So by definition, if you're sending somebody to the ER, clinically you're already worried about them. Okay? So this doesn't include all the ones that you don't send to the ER, okay? So some of the data is already going to be skewed, okay? But even the ones that you send to the ER, there's abnormal imaging in less than 5% of the patients with a GCS of 15. If they've got a perfect GCS, they're probably not going to find it. And that's even the ones that you send to the ER, okay? Abnormal imaging in 30% of the patients with a GCS of 13 or less. But if you look at the GCS, if they've got a 13 or less, that's not good. Okay, you're probably going to be sending those people to the ER anyway, hopefully. Let's see. But this is what I find interesting. Even those with an incidence of that have abnormalities, those that are needing neurosurgical intervention is less than 1%. Okay. But again, these are the ones that you don't want to miss because it's life-threatening. Okay. And this is more for my residents. You don't need an MRI. MRI is it takes a lot longer. CT is zoom, you're done, and you can find bleeds, and that's really what we're looking for. Okay? If we have more prolonged symptoms, they come to me, you know, they've already been to they had a bad concussion, they had some neurologic findings, they were sent to the ER, they had a CT scan, they're still having symptoms 3 weeks out. I'll probably MRI them just because that's the tool that we have just to make sure there's nothing else screwy going on, okay? I still know that most of the time there's going to be nothing that I find on that, okay? So just know that there are rules in the ER for ER physicians to utilize to discern who gets a CT, all right? There's a Canadian CT head rule, the New Orleans one. Let's see, but that's really just know that they're there. It's beyond the scope of this. My residents need to know them. So who gets observed for the next 24 hours? Any GCS less than 15 that's sent to the ER, any abnormal CAT scan or CT. Seizures is on here, and anybody on anticoagulation. What about outpatient? These guys who can send, that you can send home, you need to make sure that they have a person able to monitor. So if they do not meet any of this criteria and they have somebody that can monitor them, these ER guys can send them home. So this is what people always ask, and we have this on a form, which is very good. It actually lined up pretty well with what I already had on here, Jamie. So, warning signs for outpatient caregiver. We have a form that we give the parents, evidently.
We're going to start. That's why I
Excellent. Okay. All right. Excellent. Inability to awaken the patient. Well, inherent with that is that you're going to have to actually arouse the patient that first night. And there's debate on whether or not you do this or not. I actually have always kind of erred on the side of going ahead and doing it, just making sure that they can actually be aroused a little bit. You know, if they don't come fully awake, but they're like, hey, leave me alone, okay, let them go back to sleep. But as long as you can do it, because you don't want to miss that, you know, subdural hematoma that's slowly growing over time. So any inability to awaken the patient, severe or worsening headaches in that first 24 hours, somnolence or confusion, restlessness, unsteadiness, so like some specific like findings, any new seizure, vision changes, continued vomiting, okay, like if they weren't vomiting but now they're vomiting, any fever, stiff neck, stiff neck is plus or minus, fever with stiff neck, definitely. And any urinary or bowel incontinence, so pretty much any new neurologic finding, you want to make sure that they go to the ED. What about return to play? This is taken from that 2017 consensus statement and also the AMSSM position statement on concussions. Interestingly enough, all of these things are consensus statements. They're not evidence-based. It's a bunch of guys that are really old with long hair and beards that get together and decide this is what we're going to do, okay? Why do we do this return to play guidelines? Because we know that premature return to play increases the risk of sequelae or badness from the concussions. One study showed 1 in 15 players with a concussion had additional concussions during the season, so we want to try to prevent that. And also, most of these occurred within 7 to 10 days after the first concussion. So, why do we care? Because each concussion, it seems like there's an increased risk for concussions. They increase. Individuals with 3 or more concussions have threefold increase of further concussions versus those who never had one. So we want to try to prevent this. And then, really recently, what about this cumulative brain injury? So here's our return to play. If you suspect a concussion, remove them from play. And they need to be evaluated by a licensed professional. Okay? This is where you come in. This is where the physicians on the sidelines come in. If you diagnose somebody with a concussion, they are removed from practice or play. I'll go a step further and say, if you suspect a concussion, they pass, reevaluate them, hold them out, because they can fool you. If you have a high index of suspicion, trust your gut. Be conservative for children and adolescents because their brain seems to be much more malleable and it takes them longer to recover. Same-day return to play for those that are diagnosed with a concussion is not recommended in any of the guidelines, even in adults. And I like this 6-day graduated return to play, which is a stepwise increase in functional activity daily. Starts with the 24 to 48 hours of cognitive physical rest. Good thing about high school football is that you play on Friday. You kind of have an inherent built-in 48-hour of rest here that you can have. Okay, so that's good. Symptoms assessed during each day. If no symptoms, then to the next day they get to progress to the next level. Nothing that we're doing is actually getting them back faster. This return to play is proving that you are safe to go to this next level. We're not actually treating them. We're making sure that their brain is going through the natural progression of healing on its own. And we're trying not to hurt it. That's what we're trying not to do. If they have symptoms, drop to the previous level of asymptomatic and wait 24 hours. So an example would be 24 hours of cognitive physical rest after they're asymptomatic. So let's say they get a concussion, they're diagnosed with a concussion, they still have a headache the next day. On Sunday, they're asymptomatic. Well, on Monday, you can start the return to play. So something like a stationary bike for 20 minutes, then jogging for 20 minutes lightly. The next day is agility drills with moderate sprints. The next day is sport-specific activities without contact. And then there's a return to full contact participation. And so that's kind of your progression. That's the perfect world. So is it possible for them to actually return the next week at a high school level if they are diagnosed with a concussion on Friday night? Yes, it is possible. I'll tell you that if one hiccup occurs, they're out. And so you actually don't need to push them to get back that fast, okay? You're kind of out for that week. May as well just kind of slow things down, get them back, try to get them back. Don't do anything that's going to push them to where they miss the next week, okay? All right, prevention. What about helmets? Proven to be helpful in baseball, ice hockey, rugby, alpine skiing, and snowboarding. Not helpful in soccer. What about American football? Well, there's no standard in American football for helmets. What about use? There's a question of whether or not they can be used as a weapon. They're not so much anymore, but this is true. It does give an inappropriate sense of security. The game of football has gotten much rougher over the years, thanks to the pads and the helmets. So are we actually contributing to it? That's a good question. Something that has helped is the rule changes to the idea of a defenseless player and fines for helmet-to-helmet contact, etc. That has helped, it seems. What are we trying to prevent? Second impact syndrome, all of these things, post-concussive syndromes, headaches, epilepsy, vertigo, chronic encephalopathy. And we'll go through these pretty quickly. Second impact syndrome is essentially where same day you either miss or you diagnose a concussion and you let them go back in. They get hit again, and essentially they get diffuse swelling, and then they die. Cause is thought to be disordered cerebral autoregulation causing cerebrovascular congestion and malignant cerebral edema. Their brain just essentially swells so much that they herniate and they pass away, unfortunately. It's rare, thank God, it's rare, but there are case studies. So you don't want to be the one that caused it, okay? And there's no type of person that you can actually say, well, this person is at risk for this. This just seems to be a random thing, okay? Yeah, it's not typically seen in boxers. That's the interesting thing. Post-concussion syndrome is simply prolonged neuropsychiatric symptoms after a concussion. So technically speaking, 80% of patients with concussions have this. It's anyone that has a concussion and still has symptoms on Monday, like if they get a concussion on Friday. So post-traumatic headaches or prolonged headaches that begin 7 to 10 days from initial concussion. Some say that it should be within 3 months. Most end up with scans. But again, this is what we're trying to prevent, okay? Post-traumatic epilepsy, again, is very rare, associated with a twofold increase in, MTBI is associated with twofold increase in risk of epilepsy for 5 years post-MTBI. Good thing is that it's still rare. So even though it's a twofold increase, absolute numbers, it's still pretty small. And we kind of mentioned earlier, anticonvulsants don't prevent this and therefore aren't recommended, okay? Vertigo can occur. It's where shearing occurs, displacement of the otoliths, typically worse at onset, and they gradually improve. And then CTE. I think this is one of the last things that we're going to discuss here today. It's the cumulative effects from multiple concussions, increasing severity and duration of mental status abnormalities after MTBI. You end up with long-term cognitive impairment, long-term behavioral changes, personality changes, depression, suicidality, Parkinsonism, speech abnormalities, gait abnormalities, and this is what the brain looks like, a normal brain and somebody with CTE. There's also, CTE is a very defined, it's more defined now. There are others as well that don't have these specific findings, but it's kind of like they can all be grouped together in like repeated concussions causing these types of deleterious effects. And so this is, again, what we're trying to prevent. What we don't know is what about all these micro-concussions? You know, a lot of these players that we're seeing come down with this are NFL players. Well, they've been playing since Pop Warner. And so what about all those hits that they consistently had that never got a clinical concussion? That's the big question mark that we have nowadays. So is long-term playing of football, is that in and of itself the risk? It's not necessarily all these concussions that you're having. Or are you having all these major concussions and you're getting back too soon, and that's what's causing it? So that's what we're still looking into. In the NFL, there is an increase in reports of dementia. These are cohort studies of NFL players with multiple concussions, and they do have disease-related mortality 3 times higher than a U.S. population. Now, again, this is not your general population, so can you draw this correlation from those who are in the NFL to your high school athletes? And that hasn't been correlated yet, okay? There are case studies of individuals who have multiple concussions, even at the high school level, that do go on to commit suicide, and then they do postmortems and they have changes. But it's typically those who have suffered multiple concussions, okay? And again, it's not, if you look at the number of people that play football at the high school level, the millions of kids, and there's just case studies of these individuals that do this. So it's very rare, okay? So Now you know, be careful about getting people back too quickly. Err on the side of safely. And the younger they are, the more conservative I think you should be. This was just a video of a little kid who's like 7 years old playing Pop Warner football, maybe a little bit older, and he just rocks this other kid. But so it begins early in life with some of these kids, okay? All right, questions?